I've recently reported on 2 different studies that we performed at The Ohio State University. One was an evaluation of SEER data, and one was using the Flatiron database. We've published the SEER data in Blood Advances, and we recently presented the Flatiron database data at ASCO, and we are currently working on our manuscript. So I'm really excited to talk about this topic because it's something I'm very passionate about, and something that we, as clinical investigators, really need to be better at. How do we make sure that our minority patients are deriving the same benefit from these costly medications than our non-minority patients? Because notoriously, we are really not great at recruiting patients to clinical trials. And obviously, there's a whole bunch of data out there that minority patients just don't do as well in terms of their health as non-minority patients. So the first study was the SEER database. So the SEER database, just to remind all of you, is a United States database that has patient characteristics extracted from 17 different registries. And what we found here was that Black patients continue to fare worse than white patients when we look at all of these patients across the United States, even in the modern era of therapy. And how we defined the modern era of therapy was looking at patients who were diagnosed before 2014 and after 2014. Because 2014 was when ibrutinib was first approved. And what we found was that the disparity was much worse pre-2014, but it was still present after 2014. And unfortunately, this data, we don't have patient characteristics, so we don't know whether or not there was higher rates of comorbidity that might explain this. We don't have treatment received, but overall, it was still alarming to see that this disparity still existed, although smaller after 2014. So where do we go from here? We have to figure out the why this disparity exists. So cue in the Flatiron database. So the Flatiron database is a data that is extracted from both community and academic settings. You have to have been seen by a hematologist, oncologist, and you have to have received treatment. So this database is very different than the SEER database, where in the SEER database, we don't know what the access to care looks like. We don't know what treatment patients received, and we don't know whether or not those patients ever even saw a hematologist oncologist, right? So in the Flatiron database, it sort of is more of an even level playing field, at least in terms of access to care, but it is still a little presumptive that everyone had access, but at least I can say that they had access to a hematologist oncologist, and they most likely had access to treatment as well. So in the Flatiron Health database, we had previously reported that despite higher use of small molecule inhibitors in Black patients, which we observed within this database, Black patients continued to fare worse than white patients. However, in the manuscript that we're working on now, that finding has changed a little bit. And that finding now is showing that what it looks like is when patients are treated the same, they actually are living the same. So the disparity actually goes away when they're treated the same. What happened was we realized there was an issue with lead time bias, and when we corrected for it, it looks like Black patients actually look like they are doing as well as white patients when they are treated the same, which is exciting data. Other things that we found was that Black patients were more likely to have deletion 11q, were more likely to be IGHV unmutated, and have less deletion 13q. So it's one of the first papers where we have described genomics being different between Black patients and white patients, which is important for future research. So ultimately, when we think about disparities, I think these papers show us that access to care is incredibly important. And whether that be access to clinical trials, whether that be access to a hematologist oncologist, I think that once patients have that access barrier removed, they do much better, and we have to work on making sure that our Black patients have equal access to medical care as do our white patients. And so I think that's where I would focus my money if I had it to help decrease this disparity with patients with CLL.